sensory kind of ligaments. Some of these are little blood vessels, little bitty arteries, little bitty veins. Here's the nipple out here. Generally, mammograms are taken in two views. One view is with the plate below and shot down through the breast, and one is with the plate lateral, shooting out through the breast to give you two 90-degree views of it. The amount of radiation in breast mammograms is so low now that it's really not an issue. Not that you want to go having one a week, but certainly there's been a lot of debate, and I always hate it when there's debate because I think it really confuses patients. For a long time we always said you ought to get your first mammogram when you're 40. And the only exception to that was if you have a family history of breast cancer, you ought to get your first mammogram when you're 35. And then from 40, you ought to get one every year or every 2 years from then until you're 50. And once you're 50, you ought to get one every year the rest of your life. Now, the thing to remember, the thing about breast cancer, and I took care of hundreds of cases of it, breast cancer in old people is a pretty benign disease. In other words, yeah, old people get breast cancer a whole lot more than young people, but if they've lived to be 60 and haven't gotten breast cancer, with surgery and your treatments, they're probably going to kick it. They're probably going to make it. The ones that don't make it in breast cancer, and the one that's always such a tragedy, and was such a reason that the Susan Komen Foundation is able to raise billions of dollars for breast cancer research, is because when it attacks a young lady, excuse me, young ladies like in this room, that's when it really stings. And because those are the ladies that generally develop the worst forms of it and do the worst with it. So I think every surgeon can remember one or two young breast cancer patients who they lost, because you don't lose that many old ones. You lose the young ones. Yeah.
Does that have to do because young women aren't getting mammograms very often? Is it because it later?
No, it's because they develop a more virulent form, a worse form of it. And as far as catching it early is concerned, the trouble in young ladies is it grows so fast that you might have two mammograms that are a year apart and it wasn't there on the first one and now it's big on the second one. I mean, that's just kind of the way it works.
For my sister-in-law's case, where I'm 43-year-old women don't get breast cancer. That's an old lady disease.
The most common age to get breast cancer is 54. And so half of people who get breast cancer get it older than that. Here's a patient with an extra nipple. Here's a primary nipple. Here's an extra one. Some ladies have as many as cats. You know, so they just have a whole line of them down here. And,
seriously?
Yeah, I'm serious. And you can imagine having 12 little babies hooked on there, all having their own nipple, right?
Do they have like mammary glands?
Yeah.
Most of them don't. Most of them it's a developmental thing, and so it looks like this. It might have a little bit of breast tissue underneath it, but I can tell you most ladies who have this are going to be into the doctor long before they get to be in the 10th grade even, and you're going to take and numb it up and make a little incision about like that. And you're going to take out some tissue, some deep tissue down there as well, and you're going to look at it to see if there was any breast tissue in it, but it's almost never there. You just take them off. Yeah?
It happens to men too, right?
This does happen to men. Breast cancer happens to men as well. I only took care of 2 cases of male breast cancer in my career and probably took care of 400 women. It's supposed to be 1%. The problem in men that makes it usually worse is, first of all, men are deniers, and even though there's a lump there, they think, oh, that can't be anything, no big deal, because men are stupid. And second of all, it has nowhere to hide. I mean, whereas a woman, you can have a breast this big and have a tumor this big, and so when you take the breast off, if that's what the treatment you opt for, you know, you've got lots of normal tissue around it, so hopefully you can get the whole thing out. Whereas with men, it's usually laying right there on the muscle to start with, and so it spreads in different directions earlier, and tends to be a bigger deal. Clinical exam, this is an extra, you don't have to take notes or know much about this. Examination of the breast is really is a science and an art. It involves inspection, which means looking at the breast, palpation, which means feeling of the breast, examination of the arm under the armpit, the lymph nodes, and you always want to examine the lady first with her arms down at her sides, with her and then with her arms up here on her hips, just to move these muscles around to feel the axilla better. And then palpate the breast in a clockwise wise direction. I always would have the ladies lay down and kind of roll up on one side. The idea is if they're on their back, oftentimes the breasts are kind of flopped out to the side. And what you really want them is to roll them up, to flatten them out as much as you can. So you roll them to the position where their breast flattens out completely, and then you can palpate with your fingers, and really it's amazing what you can feel, how small a lump you can feel if you take your time and do it right. The other thing I would say is that about 85% of breast cancers are not found on mammograms. They're found by ladies examining themselves. So no matter all this fancy crap in the world, all these fancy tests and so forth, most ladies are still going to diagnose themselves if you examine yourself. Now, there's two parts to that. One is to get the ladies to do it, and the second thing is tell them not to freak out every time they feel anything, but have them just come in and see the doctor. I think a lot of times the story went like this. The lady would say, well, doc, you know, I get lumps every month. I get lumps all over, and my breasts are just lumpy. And I say, I don't care. You still have to keep examining yourself. And if you come in here next month and say, doc, I've got this lump that's been here now for 2 months, and it feels kind of different than the other lumps, we're going to biopsy it. We're going to take it out. We're going to make sure that that's not a malignancy, not a cancer. And you have to listen to the patient, even though the patient is scared, and even though the patient is unknowledgeable, has never felt a lump in the breast. You know, most ladies have never felt a real lump. And so it really requires a lot of teamwork between the doctor, the nurses. The nurses probably are more important, if not, it's certainly just as important in talking to the ladies about self-examination and so forth. Mammograms are great because they really do pick up little things from time to time. Mammograms are much more valuable in old ladies than they are in young ladies, because young ladies have active breasts. They're getting ready to get pregnant every month. Just like the inner lining of your uterus is getting ready, just like your ovaries getting ready, your breasts are getting ready too. And so they tend to grow a little bit and shrink a little bit, grow a little bit and shrink a little bit. And that's one of the things that leads to fibrocystic disease, which is lumpy breast, just scar tissue in the breast. But you can see those a lot easier in old ladies because their breasts are not as active and they're not constantly growing and shrinking. When old ladies have a much less dense fatty tissue, and so the young women's breasts appear much denser. So mammograms are just not as good in young ladies. And when I say they're not as good, that involves a subject that you probably haven't thought much about, but it's called false positives and false negatives. And everybody says, oh, you got to get a mammogram. Well, if you do a mammogram on 100 ladies that are 30 years old, I can promise you, you will probably be doing 30 breast biopsies, because you're going to see stuff. And then you're going to go in and you make a little incision, numb up a spot, and take out a lump, leave them with a scar, tell them it's not cancer, and on your way you're going. But that is a real complication. You've got a scar on your breast now that's going to show up on every mammogram. Scars show up. You're going to have a lady who's freaked out. You're going to cost a lot of money. Costs a lot of money to do a breast biopsy. All of those are negative things that were caused by you doing too many tests. You know, so There's a plus and negative with every test we do. Mammograms are certainly in that boat. I would just always stick with the American Cancer Society's recommendations. They're a little bit on the conservative side, but yet they're still very good. Benign cystic breast disease. This is a very common disease. I bet every one of you in the room, if you examine your breast closely enough, you'd find some lumpiness somewhere, and that's what it is this right here. It's kind of an irregular cyclic response of the breast to the hormones as they vary during the menstrual cycle. Ultrasound, it says here, is very helpful. I'll be honest with you, I never did an ultrasound on a single breast ever. I used another treatment, and it was called aspiration. And a lady would come in, and she's got a lump in her breast. There's a dozen cases I can remember that were exactly like this. She is absolutely covered in sweat. I walk into the exam room, she's in there with her husband, they're holding, not one hand, but holding two hands, you know, that's even more than one. And they're both just freaked out, and she looks at me with tears in her eyes, and she says, Dr. Sessions, I've got a lump in my breast. And sure enough, you examine her breast, and she's got a lump, and it's as big as a big marble, and it's obvious as hell, you know, and bounces between your fingers and so forth. And yeah, you could go send her over and get a mammogram, and yeah, you can send her over and get an ultrasound, but what I found worked virtually 100% of the time was I would say, all right, well, Mr. and Ms. Jones, here's what I think. I think you've got a lump in your breast, and we have got to know what it is. We have got to know that that is not a cancer in your breast. And what I think we should do is simply clean it off with a little alcohol and put a needle in it and see if I can suck the fluid out of it, because I think it's just a cyst. If it's just come up in the last few days, it's more than likely just a cyst. Now here's the rules. If we can't make the lump completely go away, you're going to have a breast biopsy. We're going to have to go in and take out some tissue and make sure there's nothing lurking under there. If we can only make part of it go away, you got to have a breast biopsy. I want you to come back and see me in a month, and you have to come back. You have to agree right now that you're going to come back in a month. And if it comes back on you, if the lump comes back, you're going to have a biopsy at that point. But if we can aspirate it and make the lump completely go away, and there's nothing left and nothing comes back in a month, you're done. We don't have to do anything else. We know it's just fibrocystic disease. And, you know, I can't even remember one that didn't aspirate. And you just put the needle in and you suck the 5 or 10 cc's of fluid up into the syringe. And you say, Ms. Jones, look here, here's your lump. It's up in the syringe. And Mr. Jones is jumping for joy over there. And it's about as positive a stroke as you can ever get in surgery, I guess. And just say, you know, okay, it's gone. I can't feel anything here now that it's gone. Come back and see me in a month, and we'll examine it again. If it stays gone, you're done. You don't have to worry about this. Please don't go home and worry about it. It's nothing. But that's the story of fibrocystic disease. And the big problem with fibrocystic disease is that most everybody has it to one degree or another. The only importance it has in any way is that you have to rule out cancer. A lump is a lump is a lump until you prove it's not cancer. That's just the rules. Here's an example of a piece of breast tissue here. This is all scarred and fibrous, cystic, and it has a big hole in the middle of it. That was a cyst. Here's what it might look like on an ultrasound. And you can measure it and do all these fancy things. But like I said, I never ordered one. I just put a needle in it and see if I can make it go away. And usually you could. Fibroadenoma of the breast is a benign tumor. This is the ones that you just need to have removed. These occur in young 13-year-old girls, 14, 18-year-old girls, and they can get really huge. They're kind of rubbery feeling. We used to call them mice because they would kind of move around like a mice. You could push them around in your breast, it seemed like. All you had to do is remove them and they didn't come back. Here's a fibroadenoma right there, fleshy tumor, not cancerous at all. This is what happens when ladies don't examine themselves. I can tell you that my grandmother, I am sure that my grandmother never touched her breasts in her entire life. In fact, she would have been offended if she had heard me call it a breast. It was a bosom. That is my bosom. And she never examined herself, never touched herself. Just, you didn't touch sexual things, right? When in those days, you just didn't. And I had, these are ladies that, I had several like this. This is an old lady who comes in. Her entire breast is a big solid rock. It's a cancer. You can see the nipple is inverted. It's pulling the nipple in. That's a breast cancer. This is inversion of the nipple here. It's being pulled in by a breast cancer that's out here in the breast. This is a change. Whenever you see this, you need to get them right to the surgeon. This is a very malignant form of breast cancer. The findings here are called peau d'orange, the skin of an orange. And if you look at that, you see how there's little dots, and there's a lot of edema right in the skin, and that condition is caused by the subdermal lymphatics. The lymphatics that are right there in the skin getting blocked with cancer and leading to this orange skin kind of appearance. That's a really a bad deal. And there's a cancer underneath this. I think that's what this arrow is pointing at. Another one. I mean, I remember asking her, I said, what? What? Did you not see this? Did you not feel that?
Yeah.
And that would be like my grandma, because I can promise you, I'm sure she never stood in front of a mirror looking at herself. That would have been sinful. And to touch it would have been just about as sinful. And so, you know, we used to see things like this. I think I saw probably 7 like that in my career. Okay, let's talk a little bit more about the reproductive system and the hormones and the cycle. We've kind of glanced at it a few times already. But basically remember that the female reproductive cycle runs because of the pituitary and because of the hypothalamus, right? The hypothalamus secretes those releasing factors that then cause things to be released by the pituitary, and it creates this complex pattern that causes everything to be stimulated once a month. And if you get pregnant, you stay pregnant. If you don't get pregnant, everything starts over again, and you go through another cycle. The thing that really regulates our reproductive function in females is the gonadotropin-releasing hormone. It's released by the hypothalamus, and its pulse frequency, in other words, how often does it release a little bit of gonadotropin-releasing factor, changes throughout the cycle. Changes in its frequency are controlled by the estrogens. Estrogens make it pulse more frequently. Estrogens say, yeah, let's get pregnant. Let's release a little more female hormone. Let's get pregnant. Progesterones tend to slow it down. There's 5 functions of estrogen that you probably know or have thought about. One is, you know, that estrogen stimulates bone growth. And indeed, in little old ladies who fall and break their hip, they almost fall and break their hip because their bones were weak. They had osteoporosis, and that's generally because they've been 10 years or 15 years past the menopause. And once you pass the menopause, you don't have enough estrogen in your body, and your bones tend to get brittle and weak. If you had me for 231, I'm sure you heard me say that little old ladies don't fall and break their hip. They break their hip and then they fall. The bones just get so weak from osteoporosis that literally a step or anything will cause the bone to break, and then the little old lady falls down. I've fallen and I can't get up. Yes?
So, does the birth control pill help?
Let's talk about that in a few minutes.
Okay.
Okay? That's a good question. The other thing estrogen does is makes you sexy. Distributes body hair, adipose tissue, mostly in your breasts and on your hips. It makes you sexy. It affects the central nervous system, makes you think about sex. I know you women probably don't even want to think about it a lot of times, but estrogens really do increase the sexual drive. It maintains all the functional reproductive glands and organs, all the other things. We talked about the breasts and ovaries, lining of the uterus, and so forth. And it initiates this repair and growth of the endometrium. Every month, the endometrium is going to get thick again, hoping to get pregnant, okay? If it doesn't happen, you have a period. Out goes that endometrium. You start building new endometrium for the next month. Okay, this is one of those complicated slides, like for the cardiac cycle. And in the cardiac cycle, we had, you know, like the EKG was up here, and the aortic pressure was here, and the ventricular volume was down here, and all that stuff. So pay attention. Watch this. First of all, we know that we call, here's day 1, and here's day 28. Okay? Wait a minute, what's this? Yeah, day 1 is day 0, I guess, right here, the first line. Okay, so what's happening around your body as you go through a cycle? Well, it starts off with, you've got a few, this is the frequency of the pulses of gonadotropic releasing hormone. You see it starts off here about 10 every day, and then it builds up to maybe 50 a day. And this is when it gets to be that many, that's when things really start happening. And you have a lot of, that signals, and a lot of FSH is released, and a lot of LH is released right here. And this is what is going to lead to ovulation, because ovulation is going to occur right here, as illustrated by this little picture. This line here is what happens to the ovary. This is what's happening in the ovary. So here it starts out as a primary follicle, becomes a secondary follicle, becomes a tertiary follicle. It ovulates as a primary oocyte, right? And then that area of the ovary turns into a corpus luteum. Corpus luteum is yellow looking, and the corpus luteum starts making hormones like crazy. It really makes the progesterone. Now, progesterone, you've heard of it before. Birth control pills contain small amounts of both estrogen and progesterone in them. Progesterone is aptly named. It's pro-gestation. It is pro-pregnancy. Okay? Progesterone is what keeps your pregnancy going. So, assuming right along in here you got a sperm met up with an egg, say here at day 15, 16, 17, right along in there, then and your corpus luteum is pumping out the progesterone, and that progesterone is saying, hey, Mr. Uterus, stay pregnant. Accept that implanted egg. Allow that thing to implant into the wall of the uterus. Allow that thing to grow, okay? And it does that, and you see this is corpus luteum, and mature corpus luteum in the late 20 days, like here's 21, up until say 25 or so. And if there isn't any feedback from that fetus and from that placenta, because that placenta is going to make hormones as well, which are going to signal back to keep it going, and they're also going to start making progesterone themselves to be pro-pregnancy, right? Then the corpus luteum starts withering away. It turns into a corpus luteum, the white, turns into a corpus albicans, the white one, and goes away. And once the progesterone goes away, which happens right about here, boom, here comes the menstrual period, and off falls the endometrial lining over here. So here's here's the hormone levels from the ovary. The estrogens are coming up. They peak right before ovulation, and you ovulate right here, and down they come. Your inhibin is hanging in here. Here's your progesterone. Remember, the progesterone is manufactured in the corpus luteum up here. So when you get a mature corpus luteum, this baby is coming up, more and more progesterone, more and more, let's get pregnant, let's be pregnant, let's stay pregnant, up here, and then here's this mature corpus luteum still making, but then wait a minute, we didn't get pregnant, it gets disappointed. And so the corpus luteum becomes a corpus albicans, it becomes unfunctional, quits making progesterone, progesterone level drops, and lo and behold, you have another period. Yes.
So corpus albicans does not make progesterone.
No, corpus albicans it's a corpus luteum that's just turning to scar. It's just becoming scar tissue. That's why it's white. Okay. So what's happening? That's what's happening in your ovary. Oh goodness. Uh-oh. What did I do? Oh, that was terrible. Okay. So that's what's happening in your ovary right there with all these hormones being released. There's what's happening physically in your ovary with that cell getting ready to be thrown out. Here's what's happening on the wall of your uterus. And the first 5 or 6 or 7 days you're having a period, and so this whole thing is falling apart, and that, all that extra secretory membrane that built up and got so thick to receive that little baby, that little fertilized egg, is falling off. And so by about day 7, 5 to 7, your period ends, and now it's time to start building the lining of your uterus back again to get ready to get pregnant next month. So here you go, you're day 7, you go into this proliferative phase. It's proliferating the number of glands, and the spiral arteries are opening up and sending more blood out here. And this is getting thick and rich and moist and all kinds of healthy. And then here in the secretory phase now, it's got all the glands have been built. They're all secreting fluids. This is a wonderful place now along in here for that fertilized egg to land. So sure enough, it's probably going to land right along in one of these days right here. And if it lands, it's going to turn this black line from a downward curve to an upward curve, right? Because the placenta and the implanted fetus are going to start making progesterone as well. And otherwise, if it doesn't happen, you don't get pregnant, the progesterone level drops off. And when it drops off, the menses starts again right here. And all these extra layers just fall off, and you have another menstrual period. So, you should be able to identify under the microscope the three different stages of the uterine wall. One is the menstrual cycle, and in this one you'll see chunks of membrane coming off. You'll see blood scattered in amongst it. Then it starts here and it's really thin. There's hardly any secretory layers, and then when you get on out here, there's lots and lots of these glands that are quite obvious. So that's the 3 phases, and as I've told you, I'm not going to give you a picture of one phase and say which one is this. I'm going to give you 3 pictures and ask you which one is which. Okay, so you'll have something to compare it to. I don't know, I couldn't do it otherwise myself. The last curve down there, excuse me, that's your purse, not your foot. That's good. Depending on what's in your purse.
Foot heels, things in purses break.
This is your basal body temperature. Back in the day, back in the 40s and 50s, women who were trying to get pregnant were told, keep the thermometer beside your bed every morning before you get out of bed. Put it under your tongue for a full 5 minutes. Measure your temperature exactly and mark it and write it down on a piece of paper. And then if they found this spike here, which is normally a degree or degree and a half, go up there, that's usually occurs when ovulation occurs. A lot of ladies know when they ovulate. They feel a little pain. Obviously you're busting your ovary open a little bit, and when it busts open and throws that egg out, it bleeds a little bit at least. So most people, most women, if they pay attention, and you got to pay attention, they'll figure out that, oh, you know, yeah, I always ovulate on day 14. And the husband says, great, I can't wait for day 14. And they, you know, start going for it on day 14 in order to, if they're trying to get pregnant.
And they don't get pregnant.
And sometimes they don't, that's right.
You gotta do it on day 12.
There you go. Anyway, so that's really all that has to say. Upon ovulation, the body temperature declines noticeably. I think that's a very poor technique. You know, it's kind of like the rhythm method. It just doesn't work very good. I don't know. Oh my God, what's this? Sexual intercourse is the process of inserting semen into the female reproductive tract, also called coitus or copulation. It has lots of names, so I'm not going to go any further. Male sexual function is pretty much caused by parasympathetic output. And remember, parasympathetic is rest and digest. It's like, hey, rest and digest, let's have a little sex here, right? And indeed, it's the parasympathetic output that leads to an erection. And just in case you ever wonder why men seem so selfish towards the end of the sex act, it's because that becomes totally sympathetic. That becomes fight or flight. The ejaculation and emission is a sympathetic activity, and he doesn't care what in the world is going on around him. He's got this function to do, and it's sympathetic, whereas the whole arousal thing and all this was parasympathetic. At male sexual stimulation, these glands, especially the bulbourethral glands, remember those are the ones that are found in the little muscle layer. They lubricate the penis, surface of the glands, and then it eventually leads up to this coordinated process of emission and ejaculation. Now remember that emission and ejaculation occurs from four different things shooting off all at once. One is the ampulla of the vas deferens. Remember that little distended part of the vas deferens at the end? Well, it's got to squeeze down because that's where the sperm are. Okay? The prostate gland makes 30%, I think, of your semen, so it has to contract. The bulbourethral glands are the little bitty ones, and the fourth one is those seminal vesicles. Remember, where the seminal glands that are hanging off the back of the bladder, they've got to squeeze down and throw in their 60% worth. So all those have to come together and work at the right time in order for this process of emission and ejaculation to happen. And it all has to mix together just right in order to control the pH and fructose levels and all that stuff to make this thing successful for making babies. Emission is, like I said, is under sympathetic stimulation, which is really why men are kind of out to lunch during that phase, and they certainly don't care about you during that phase, just so you know. Peristaltic contractions of the ampulla push the sperm out, the seminal glands contract, the prostate gland contracts, and this is under sympathetic control. Oh, one other thing that would be really nice that you probably haven't thought about is, wouldn't it be nice if you would close off your internal urethral sphincter? If you close off your internal urethral sphincter, the stuff will go out instead of going back up into your bladder. Okay? And that is called retrograde